Hello everybody, welcome. Everyone's starting to stream in now to the webinar. I've opened it up and given everybody access. So while we're waiting for everybody just to funnel in, my name's Jodie Livesley. My dogs always want to say hello also, so that's Olive and Mia. My role is sector support and development for providers of the Commonwealth Home Support Program, and I also have the amazing privilege to be the chairperson of the Central Coast Dementia Alliance. While you're coming into the room, we'd love for you just to pop in the chat what your name is and what your position is, and that will help us gauge where people are coming from today, if you're in community care or what department of health you're in, if you're a GP or a practice nurse or manager. So it would be fantastic if we can get started just by saying a little bit of a hello as we wait for the participants to pile in. We've got about half of the people that have registered popping into the room as we speak. So welcome to you all. Thank you, Nicole. Good to see you. Awesome to see everybody coming in, and some lovely members of our Dementia Alliance are joining us again today as well. Sorry, dogs always do this, don't they? They love to just have a chat when you're unmuted. So we'll get started. We have a big day. So I'd like to acknowledge the traditional custodians of the land that we're meeting. I'm on Darug country, so I'd like to pay my respects to elders past, present and emerging, and acknowledge any Aboriginal or Torres Strait Islander people who have in the space with us today. And getting underway, I would like to introduce to you our guest speaker, the esteemed Tamiko Barrett. He's a geriatrician, and I'll let you do your own introduction. Tamiko, can you hear me okay? Shirley's saying she can't hear you. You might need to just adjust your volume. There's 2 volume settings if you can't hear well. There's one on the actual computer or device you're using, as well as a Zoom volume audio setting, which will be the drop up arrow on your screen. So I'll introduce Tamiko and we'll see how we're going with the volume. Thank you.
Good morning, everyone. So I'm one of the geriatricians based at Wyong Hospital, and currently I work as a community geriatrician, but I do rotate through all of the other positions, acute geriatrics and rehabilitation. Thank you very much, Jodie and Deb, for organising this webinar. We were attempting to do this for Dementia Awareness Month in September, but COVID caused a delay, as it's caused to many other things. So thank you for all attending, even though it's not in the right month. Now, is there any problems with the volume before I launch into the talk?
I can hear you just fine.
Great.
Yeah, I just forgot to mention, sorry, I was distracted by my dogs. If you have a question that you would like us to answer, Tamiko to answer, can you pop that in the Q&A function, which looks like 2 speech bubbles down the bottom. If you want to just make a general comment, you can pop that in the chat. Thank you.
Okay, so today's topic is dementia, behaviour and psychological symptoms of dementia and the new laws. And I think the reason I've chosen this image that I took in Botswana many years ago is because I think that for many people, particularly working in aged care facilities, this has seemed like a charging elephant. And certainly sometimes here in the acute hospitals, the patients with BPSD certainly feel like charging elephants. I'm hoping that from today's talk, you won't feel so anxious as if you were facing that elephant there, but have more understanding about what to do. So this is the outline of what I propose to talk about. What the definitions are, both from the BPSD and the new terminology, the results of the Royal Commission that were released late last year and early this year, and then those contentious issues about consent, review of medications, who's responsible for all of this. I'm going to outline some best practice for BPSD, and I have seen that there's a lot of people in the audience who I know are already really good at this and probably could give the talk, so we might not spend a lot of time on that. And at the end, I've got some resources and further reading and time for discussion. If there's anything that you particularly want to ask, especially as I'm going through the seminar, please put it in the Q&A and we'll try and address those at the end though, because it's tricky for me to see the slides and the Q&A at the same time. So behaviour and psychological symptoms of dementia means that, has other names are behaviours of concern. We like to think of it as behaviours of unmet needs. Sometimes you might see it referred to as changed behaviours. We know that most of the patients with dementia throughout the trajectory of their illness are going to develop complications. These complications include delirium, depression, anxiety, often hallucinations or delusions or altered thinking. And then as the dementia reaches a moderate to severe degree, then patients with dementia have a lot of difficulties communicating what their needs are. So here on the right side of your screen, you can see Maslow's hierarchy of needs, which I'm going to refer back to. Every human has these needs, and if we don't actually address them, people will be unhappy, frightened, angry. They'll do whatever is needed to meet them. So it starts off with the basic biological and physical needs. We all need to have oxygen, air, so people without enough oxygen become confused and delirious. We need our nutrition and hydration. We need to feel safe and warm, be warm. We also need to feel that we are protected by the law and have security, which if you don't understand what's happening around you, as many of the people with dementia do, that need is not met. We need to feel belonging and a sense of affection. And for many people with dementia, that need is not met, particularly during this COVID era when people don't have their families visiting, or for people living in aged care facilities, a huge restriction on visitors, a huge restriction on demonstrations of affection. We're not allowed to touch people or hug people. I think the two at the top are ones that we frequently don't think about for people with dementia, but we need to feel esteem or self-worth. And so for a patient who is repeatedly told, don't get up, you can't walk safely, I'll take you to the toilet, you can't take yourself to the toilet, you haven't put those clothes on correctly, all those sorts of things mean that their self-esteem is incredibly low. And building that up can help a lot to meet then patients' needs and then help them have, I guess, less challenging behaviour for us. So moving on. The other definitions that we need to talk about are the terms restrictive practices, because this comes up all the time in the Age Commission results. So restrictive practices refers to any intervention that has the effect of limiting or restricting the rights and freedom of movements of the care recipient. So we have physical restrictive practices. Now, I'm hoping that nobody is using posy restraints or manacles these days. They did when I first trained as a registrar in geriatric medicine back in the early 1990s. But I know that we still use furniture. So tub chairs that somebody can't get out of, rails on beds, high-low beds as we use in the hospitals are actually used to keep people in place, and they are a form of restrictive practices. And even more subtly is the environment. So having a locked ward in a hospital is a restrictive practice, and having a locked ward in or locked rooms in an aged care facility where we don't give the code numbers to the residents to leave is a form of environmental restrictive practice. Please don't feel scared and think, oh my goodness, we're going to have to change everything. You don't. We just need to find ways that we're doing these restrictive practices safest and in the legal manner. Chemical restraint usually is we're referring to the medications that we use, that is the primary purpose is for influencing the patient's behaviour. So if the chemical restraint or the drugs are for treatment of an illness, for example, a patient who has hallucinations or paranoid delusions, either as a result of their schizophrenia or of their dementia, that is a medication that's used as treatment for a health condition. And that's not a chemical restraint or restrictive practice. But if we are using it because the patient is angry and throwing chairs or punching other residents and other staff, that is to control behaviour, and it's classified as a restrictive practice. So we all heard about the Royal Commission last year. It was on mainstream media almost every day, and we heard a lot of sad and angry stories from families about excessive sedation or physical restraints, keeping patients in bed or in chairs with horrible outcomes. What we didn't hear is the background to those stories. So we didn't hear about the severity of patients' dementia, their lack of understanding. On the mainstream media, we rarely heard about the difficulties that staff in care facilities or the hospital have in providing the care because of the environments that we have to work in, because of the other patients' healthcare needs or care needs, and because of our staffing numbers. The Royal Commission did hear those stories, and they are published in their extraordinary long reports. And as a result, and they were very carefully weighed up against individual patients' needs, what the current services are practical, what's really needed to give best care to aged people in the future in Australia. And the recommendations from the Royal Commission were extraordinarily carefully worded and balanced, without blame in what is happening. So I think that's very important, that people don't feel frightened of the results of the Royal Commission. I know that when I was visiting aged care homes last year, during that process, many staff were living in fear that they would be the next person home blamed or exposed, or the next target of the Royal Commission. But the Commission was not aiming to do that. The Commission was aiming that there would be changes in practice in Australia that would lead to better care for elderly people, predominantly in aged care facilities, but there's some extrapolation to care in your home and care in hospitals. So in response to the Royal Commission, the Australian government announced changes to address the problems, and the ones that I'm going to be speaking about are not the policies about funding or staffing, but about the medications and management of people with dementia. And for some reason, it's not going on to the next one. Sorry. Right. So why do drugs get such a bad rap, and why is this a focus for the Royal Commission? We know that antipsychotic medications increase the risk of falls, they exacerbate diabetes, the risk factors of diabetes, they increase the risk of stroke and myocardial infarction or DVTs, and all of this leads to an increased risk of death, and that is with a single dose of an antipsychotic medication, and even more so with repeated or continuous antipsychotic medications. There's very clear evidence in the scientific literature that using benzodiazepines worsens cognitive impairment, as well as increasing the risk of falls. And benzodiazepines after 3 weeks don't actually help with quality or quantity of sleep. We know that if we use any of these drugs, there's increased risk of drug interactions, and there would be very few older people in care who are not already taking some medications for their heart, lung, kidney, liver disease, or diabetes and risk factors. And if we have excessive sedation, this can lead to malnutrition, dehydration, pressure injuries, and deconditioning, sarcopenia, and again, falls. I think the major thing we really need to be thinking about, though, is that using the medications is not addressing the underlying problem that's driving the behaviours causing us problems, so that the unmet need remains unmet. So this is a summary of the recommendation 17 from the Royal Commission. It's probably fairly small on your screen, so I'm just going to go over a few things. So it recommended that by the beginning of next year, the use of restrictive practices in aged care would be based on an independent expert assessment. The Royal Commission didn't say who that expert assessment should be done by, and at the moment that is still a matter of discussion and debate within the Ministry of Health in New South Wales, and with both physical health, so geriatric medicine, and older age psychiatry, and whether or not this independent expert assessment can be done by non-doctors. It also said that there needs to be ongoing reporting and monitoring. So they're really quite specific about what it needs to be in terms of the monitoring. And I'll come to that in a moment. Of course, you can use restrictive practices in an emergency. So if a patient or a resident in an aged care facility, a patient in a hospital, their behaviours are putting themselves at risk of injury, other residents or their family members at risk of injury, or the staff of injury or harm, then restrictive practices can be used without consent, and they can without all of the other guidelines that I'm going to talk about down below here. But an emergency is truly an emergency, and if it's happened once with somebody with dementia, we know that there's a risk of it happening again. So you can't have repeated emergencies every night of the week. You need to be, once it's happened once, you need to plan that this could happen again. So if we see what else the recommendations were, the restrictive practices should only be as a last resort to prevent serious harm. They should only be to the extent necessary and to be proportionate to the risk of harm. Now, this is really important when we look at what the risk is, because there are a lot of times I'm called to see a patient who is confused, has impaired distance, depth perception, is weak or incoordinated, and is getting up and walking around and has a risk of falls and then a risk of harm to themselves. But that's a fairly low risk, and if you balance that against the risk of giving major tranquilizers or benzodiazepines, it's, I'm not very good at statistics, but I would say that they are probably equal. And so there's a vast difference in what is necessary for somebody who's wandering with a risk of falling against somebody who is punching, hitting, breaking the windows and doors. The restrictive practices should be only given for the shortest time possible, which is to ensure the safety of the patient. And if they're used, there needs to be monitoring. So in the hospitals, if we're using chemical restraint, sedation, we need to do all the airway, breathing, circulation monitoring, but we also all need to be monitoring hydration, nutrition, pressure areas, and preventing deconditioning. And there needs to be a regular review, which is stipulated in the behaviour support plan. And that behaviour support plan, I'll come to probably about 50%, halfway through the talk. The restrictive practices have to be used in accordance with the relevant state or territory. Remember, the Royal Commission was national, but in fact, the rules about consent vary according to each state. So I'll talk about New South Wales laws and how it applies to us. And if it's chemical restraint, it has to be prescribed by a doctor who has documented the purpose of the prescription. So that is something to, if you are working in an aged care facility, the staff of the aged care facility can't be the ones who give the purpose. It needs to be the prescribing doctor. Okay, so recommendation 65, which was by November, so in less than 2 weeks' time, is that if we're using antipsychotics in an aged care facility, that they can only be prescribed by a psychiatrist or a geriatrician. they can only be initially prescribed by a psychiatrist or a geriatrician. So of course, within New South Wales, particularly here on the Central Coast, there are no resident psychiatrists and geriatricians attached to aged care facilities. We're all visiting and by invitation or consultation request only. And so almost all the prescribing in an aged care facility is done by the general practitioners. Some of the initiation, we've seen some of the patients, but we haven't seen the vast majority of them. So this is something that we're really going to, as a team of people, by which I mean geriatric medicine and older persons' mental health, the private geriatricians and the aged care facilities are going to need to work on together, again with the PHN, to ensure that we are compliant in our area, meeting best practice for our patients. So for those people who have received an initial prescription from a psychiatrist or a geriatrician, the GPs can issue the repeat prescriptions, but only for a year. And then there needs to be another review by the psychiatrist or the geriatrician. And in fact, the general practitioners have to do a review every 3 months of whether or not they're going to continue that prescription. Again, this is because one of the big problems was people started on an antipsychotic or a benzodiazepine, and they continued on it forever. People weren't reviewing it. But we know that as dementia progresses, as people's family and social circumstances change, that often those BPSDs can resolve, new ones can emerge, but usually the antipsychotics are not needed for more than a year. So there were major changes to the law within Australia and New South Wales on the 1st of July this year. So some psychiatrists around the state think this is the equivalent of the Big Bang for geriatric medicine. So the amendments were to the Aged Care and Other Legislation Amendment Acts, and these, for anybody who's actually really interested in the law, these are the two acts that changed: the Aged Care Act 1997 with amendments for 21, and the Aged Care Quality and Safety Commission Act 2018 with the July 21 amendments. This is a summary. You don't need to go and read all the legalese about what those amendments are. So I phrased this in terms of what it specifies and how that relates to what we can and should be doing. So again, the amendments that came in are as a last resort to prevent harm to the care recipient or other person, and after consideration of the likely impact. So that means if you're using restrictive practices, you need to consider all those harmful things that I talked about earlier with the harm of the drugs. To the extent possible, alternative strategies are used before, and those alternative strategies have to be documented. So it's no longer adequate just to prescribe without documenting alternative strategies, and it's no longer adequate to just write all behaviour management strategies tried, no behaviour management strategies work. Actually, you need to write in the aged care facility progress notes what those behaviour management strategies will be. Now, it may be that you have a care plan or a behaviour management plan, and of course in the progress notes you can write that you've tried A, B, C and D on the care plan or behaviour management plan and it didn't work, or it worked for a certain length of time, but it must be documented, and aged care facilities will be audited about this. Again, I talked earlier about that the restrictive practices that are necessary have to be in proportion to the risk of harm to the care recipients and other people. And this is something that we really haven't in the past weighed up very well about what that risk of harm is. And when we're doing that, we need to be looking at the person's previous expressed wishes or their lifestyle, and we need to be discussing it with their family members, carers, or substitute decision maker about the view on the risk of harm, which then we also can incorporate into that discussion the risk of harm from the restrictive practices as well. They need to be the least restrictive and for the shortest time. So that means that in any prescription of a physical restraint, such as a tub chair, the high-low bed, it needs to actually say this patient should be cared for in a tub chair or high-low bed for this amount of time, and then the plan afterwards. And there needs to be informed consent. Now, that's a really tricky one, and I've got slides about the informed consent coming up. Now, we need to remember that people living in aged care facilities have the same rights as every other person in Australia. And so if we are holding people in a facility, we're restricting their rights, and we would not do that to Jodie or Deb, who've organised this seminar. Hopefully nobody would do it to me, though I'm sure some of the people I work with would love to lock me up. But it's not allowed, okay? So don't get any ideas about the quality of this seminar and locking me up. And we need to make provision for, in that prescription of the restrictive practices, for monitoring and review, and it needs to happen. So aged care facilities are actually going to be audited again on the monitoring and the review. Right, so in practical terms, what are the aims and what should we do differently? So we need to have better and much more use of alternative strategies. We need to have better documentation. We need to get the consent, and we need to be having evidence-based use of the medications with a scheduled review and deprescribing. Now, this is an enormous one, the deprescribing. Patients continue on medications for a long, long time after they're necessary, not just antipsychotics. There are thousands, if not millions, of 80-year-olds and 90-year-olds in Australia and around the world who are still taking drugs for lowering their cholesterol when there's absolutely no evidence of benefit to them, and certainly evidence of harm for cholesterol-lowering drugs. There are lots of people who are on anti-inflammatories, so non-steroidal anti-inflammatory drugs, when they really didn't need to. People who are stuck on prednisone 5 milligrams for reasons that have got lost in the last decade, and the same with benzodiazepines and antipsychotics. So I guess what they're saying is it is possible to give better care if we all just change practice a little bit. Now, there's quite a few homes practices that are doing all of this anyway. They really are doing best practice and don't need to change a lot. But for many places, it is not routine. It's not built into the care, so that by default that it happens. It's more that, oh, somebody thought of prescribing or getting consent. Okay, so the first part of the requirement is that we use other strategies before we use restrictive practices. And whenever I see a patient who is angry, throwing punches, doing things that the care staff wish they weren't because there's harm, I think, is there another diagnosis? So the predominant one is pain, or depression, or a delirium. So we know that pain let me start again. There have been studies that looked at pain control in cognitively intact adults having elective joint procedures. And we know that that only 30% of those patients had adequate pain control. And they were people who could ask for it, who could identify their pain. We knew that they were having something that was pain, but they still didn't get adequate pain control. So pain control is much worse in patients with dementia who are not able to ask, whose pain presentations may be in a different way. But we do know that there is no change in pain perception in patients with dementia. It's just in the way that they respond to the pain. Depression is another major problem. So at least 15% of patients who have dementia, possibly high as 50%, will develop a depression at some stage during the course of the trajectory of their dementia. And it's not surprising. In the early stages of dementia, people have insight, and it is an incredibly scary thought that you will lose your faculties, not be able to remember your family, friends, important things in life. As the dementia progresses, with a cell loss in the brain, there's loss, there's loss of neurotransmitters that are important in keeping up your mood. And then if we give major tranquilizers, that will again decrease some of the neurotransmitters or chemicals in the brain that make people vulnerable to depression. So I'll tell you a little story. I have a patient at present who is a man with younger onset dementia. He's towards the end of his trajectory of his disease, and he really doesn't have any language skills left. He, about 5 years ago, he had an episode of polymyalgia rheumatica. So that means that he was stiff and sore and aching all over, particularly in the morning. He's also had episodes of gout. So in the past few weeks, he's become increasingly irritable and angry, and he has started being verbally aggressive towards his carers, and then he's become even physically aggressive, pushing, throwing, and to the point that over the weekend he was really very distressed, I will say, with severe BPSD and hurling chairs and breaking walls. So is this just that he's got severe dementia and he doesn't understand what's going on around him and he can't communicate whatever his needs are? Or does he have a recurrence of his polymyalgia? He's certainly grimacing as he gets up to walk. He's very stiff and he's bent over. So I think that this is a high possibility, because he's so angry, it makes it really difficult for me to be able to examine him and certainly to do any blood tests. But there are ways around this, and we have examined him. We've now been able to start him on regular analgesia. His carers and family also said that in the lead up to this deterioration, he was becoming very weepy. And when he couldn't find the toilet in the house, he'd start to become angry and then cry. After his episodes of bashing down the walls with the chairs, he had some recollection of it, was really apologetic, and would frequently say there's something wrong with my head and start to cry. So all of this could be a depression, and we've started him on an antidepressant as well. And of course, he's having difficulties going to the toilet. I think that is ubiquitous almost in men when they get to this age with their prostate problems. And then it gets worse when he's trying to go to the toilet. Is this pain from a urinary tract infection? Is this a retention that's making him delirious and these behaviours? So all of that need to be addressed before we move on to even looking for unmet needs. I've talked earlier about the unmet needs, but I particularly want to talk about those unmet needs of a self-esteem, of having a purpose, of having some enjoyment and having fulfillment, of feeling that you've actually been able to accomplish something. So for everybody here in the audience, I want you to think about when you're leaving work this afternoon and you're driving home, if you had a bad day at work where you didn't manage to finish any of the tasks that you're supposed to do, which was me yesterday at 6 p.m, when I drove home, I felt particularly awful because I hadn't accomplished things. Whereas if I had been able to finish even this slideshow by the time I went home, I would have felt that I'd accomplished something and felt happier within myself. And this is something that we really don't think about in caring for people with dementia, how we can help people have self-esteem, which is why I've put the photo of the Tova Tafel. This is not an advertisement for Tova Tafel, but we have a Tova Tafel here at Wyong Hospital, which is a projector that projects light interactive games where people can do jigsaws, where they can put their hands on the projected image of a jigsaw piece, swipe it over into the middle of the table, and it clicks with a little click and goes into place. Doesn't matter how good or bad you are at doing jigsaws, it will always go into the right place. And that gives people that sense of self-worth that they've accomplished something. So this is, we're very proud of this, and I'm not, as I said, I'm not advertising it, but it is an example of ways that we can help people meet that need of self-esteem. We'll talk about some behaviour management strategies, and then we need to look at environmental modulation. Is that environment too noisy? Is there something else that is happening that's in the environment that actually triggers your resident or your patient? So, for example, here at Wyong Hospital, I had a patient who who had cognitive impairment. He had a very low-grade delirium, but he was generally cooperative. Because of his delirium, he was moved from his single room on one side of the ward to the other side of the ward in a 4-bed ward right next to the window. And then he became very, very aggressive and agitated. Now, it took a while for us to work out what was happening. We tried to look at the times of this. We looked at who was in the room, what was said to him, what was happening at the time in the room. What we didn't realise was about his own life history. When we talked to his family, we learned that this man was a veteran from the Vietnam War. And then we could see that every time the helicopter landed on the helipad right outside his window, he became really distressed because we had moved him into an environment that triggered his unrecognised PSD. And so that environment, we moved him out of that environment where he didn't hear the helicopter, and his behaviours calmed right down. Okay, medication is only at the very bottom because, as the Royal Commission said, it should be the last resort. So these are the behaviour management strategies that I try to practice. We try to use here at Wyong Hospital, and I know that the BASIS team and the DABS team who come out to facilities and people's homes will do. So the first thing is we try to put ourselves in the patient's shoes to try and have some empathy and imagine what the patient is perceiving. So many years ago, I was called to see a patient who had what was in an aged care facility just locally because he had sexually inappropriate behaviour, and I was asked if I could prescribe this man hormone therapy to prevent his sexually inappropriate behaviour. When I started exploring his background and what he thought was happening, I learned that this man had long-standing alcohol problems almost his entire life. He'd lived in inner Sydney, down in Woolloomooloo, and when I asked him where he thought he was now, he thought he was living in a pub in Woolloomooloo. He thought it was Saturday night, and every time he was taken into the shower and somebody was taking his clothes off to shower him, he thought that he was being propositioned by a hooker, and it was for free. He thought he was in heaven, really, because he now had free hookers every day. And of course, that wasn't the case. But his behaviour in propositioning the nursing staff, his behaviour in touching the nursing staff was appropriate in terms of where he thought he was and what he thought was happening. And so we were able to manage this fairly simply by the nursing staff and the care staff reminding him every single step of their shower or personal care that he was in an aged care facility and they were a nurse. And I say every single step, this man doesn't have any memory whatsoever, so like a goldfish. So as soon as one step was done, if they'd invited him into the bathroom, they had to remind him again that they were nursing staff. When they help him lift his shirt over his head and he's lost his vision of them, and they can see them again, they had to remind him again, the nursing staff, and put a boundary in place. So if you put yourself in the patient's shoes, often the behaviours can be, then they can be addressed. We've talked about the unmet needs. Sometimes that doesn't work, and we need to actually then go back to ABCs, the basics, which is what we're looking at: the antecedents, the behaviour of concern, and then the consequence. Sometimes our own responses to patients will drive their behaviour. So I'm sure all of you in the audience will have looked after those patients who call out repeatedly, for example, help, help, and it can get louder and I can get squeakier, but you wouldn't like it and you'd probably tune out. So we won't go there. But those patients often have a quite advanced dementia. They often have hearing impairments, so they can't hear their own voice. They have visual impairments. Most people with advanced dementia do not process anything beyond about 1.5 meters from their face. They often aren't able to look up and look down, so they only see things that are 1.5 meters at eye level and not over their shoulders. So very, very, if you could see me, oh, you can see me probably, I think. Just if everybody who's listening just puts their hands in front of them, straight out in front of their shoulders, and then just move it about 10 degrees or maybe 15 degrees sideways, that's about the framework. If you project that forward 1.5 meters, that's what somebody with advanced dementia can see. And the rest of the world, either side of that, has disappeared. They don't process it. So these patients with this sort of behaviour will often be put into single rooms because they're so noisy, they're disturbing everybody else. They call out because they're isolated and frightened and don't know what's happening. And when they call out repeatedly because of that, a nurse or a care person, staff member goes in, asks them what they need. Patient generally doesn't know what they need, didn't even realise they're called out. But the staff member have gone in, and so they have met a need and they have also reinforced the behaviour. And so what we need to do is look at the need that's driving the behaviour and find something else that will meet that need without reinforcing the behaviour. And this is why I've put up the perfect pets here. It's not, once again, it's not an advertisement, but we've found that these little toys, which are about 50 centimetres across, really look like a puppy, battery operated, but you need a screwdriver to open up the battery compartment. And then they breathe here and they make little, either if it's a cat, it makes little purring noises. If it's a dog, it makes little happy whimpering noises. So for people with dementia, having a pet of some sort or something to hold can be really, really calming and feel like companionship and help them feel safe, so you stop that calling out. But you need to do the ABCs. So looking at the pattern, the time, the place, those involved. And again, never forget pain. You think, even if the patient says they're not in pain, look at that person and think, if I had that degree of arthritis, if I had to sit really still, even my bottom is getting sore from sitting here on my ergonomic chair for however many minutes I've been talking to you. And it's so people can be uncomfortable. Right. Now, behaviour management plans is not always that simple, is it? Everybody's probably going, oh, we've tried all that and it still didn't work. So when it becomes more complicated and you have a patient with persistent BPSD, despite putting in those basic things, there's help available. Now, the Royal Commission and the changes in law recommended a behaviour management plan. There's currently a committee working on a template that can be used. What it will be is similar to that's used in the NDIS disability sector, with very, very specific behaviours and the what's driving the behaviour and the plan or response to that specific behaviour. In our area, there's help available. So through DABS, which is the Dementia Assessment Behaviour Support Services, which is really sort of a community arm working with geriatricians, through BASIS, which has nursing staff and occupational therapists working with older persons' mental health. There's the older person's mental health. Referrals can go directly through the mental health line. And there's the geriatricians, both at Wyong and Gosford. Now, all of the referrals are here, and I'm pretty sure that Deb and Jodie will be sharing the slides afterwards, so you don't have to scribble it down because you'll be able to get the slides, won't they, Jodie? Nod if you'll share.
Yes, we will.
She's nodding. Okay. And there's also private services in this private sector. So there's private psychologists and geriatricians, private psychiatrists working out of Berkeley, Vale, Ramsay Health, and occupational therapy services, Most of the occupational therapy services have been working in the NDIS sector, but some of them are now branching out to do it for geriatrics as well. Right, now we come to the chemical restraint and best practice drugs. So this is what we need to be aiming to do as GPs, geriatricians, old age psychiatrists working with aged care facilities. We really want to clarify what the target symptom is. If the behaviour management strategies are not working and we need to use chemical restraint and medications, we have to look at the symptoms and choose the drug that is most directed at those symptoms. So if we have patients who are agitated and verbally or physically aggressive because they have false beliefs about what nursing staff might be doing to them, that this is poisoning them or they're at risk, and it's not quite delusional, we'd be using an antipsychotic. If we have a patient who has a predominant anxiety and distress leading to their agitation, we might use a benzodiazepine or an antidepressant that targets that symptom best. We have to make sure that it's evidence-based, and there's no good evidence for older antipsychotics. We know that the older antipsychotics like haloperidol and stelazine or chlorpromazine, much more sedating. So you'll get a much quieter, less troublesome patient, but that's really only because of the sedation and not because there's good evidence in targeting their symptoms. We have to be honest with patients if they're able to talk to us, and particularly with their families and carers, that this is still bucket chemistry. We're giving drugs that are going to affect a lot of neurological symptoms and pathways in the brain, not just the target symptom. But this is the best that we have available with current modern medicine. There's very little evidence for anti-epileptics, and there's really very poor evidence for using hormone therapy or hormone inhibitors for treatment of sexually inappropriate behaviours or for physically violent. So we're often asked about it, but there's very little evidence. Now, there will be times that a geriatrician or a psychiatrist may use these. This would only be after we've already tried other drugs directed at the target symptoms and they haven't worked. It's really important that for best practice, we're using drugs within the recommended ranges. So for risperidone, we shouldn't be using more than 2 milligrams a day, olanzapine 10 milligrams, quetiapine no more than 200 milligrams, and haloperidol no more than 5 milligrams a day. And I've certainly seen patients who are on risperidone 2 milligrams twice a day with PRN, that if it's not working at that dose, it's probably not going to work and you need to look at a different drug. One of the issues that I face as a doctor is I'm often asked to put the drug up rapidly. So I prescribe it on Monday and there's still behaviours on Tuesday. So Tuesday afternoon or Wednesday, I'm asked to increase it. But really that is not best practice. These drugs, yes, they all act once they're absorbed, but their maximum effect is going to be in a few days. And so best practice is titration slowly, at least 3 days. If you're using an antidepressant, then it shouldn't be titrated for at least a week, if not 2 weeks. We need to have a schedule review. Once prescribing a drug, we need to make sure that it's actually documented when the review will be for side effects. And there also needs to be a scheduled review for decreasing or ceasing it, because the BPSD is likely to resolve spontaneously. And then we need to get consent. So who gets consent? Only the prescriber has the knowledge to discuss the risks and benefits. So the consent to treatment with restrictive practices with medications needs to be obtained by the doctor. In aged care facilities, it's probably best if it's with the doctor and a member of nursing staff witnessing it so that they can understand what that consent was involved, because I'm sure that later on the family will be asking the nursing staff, not the doctor. They need to understand. And there needs to be documentation of the discussion leading to consent. Now, according to the New South Wales Guardianship Act, which specifies who can give consent when a person can't, there's a person responsible hierarchy. By and large, patients with dementia who have behaviour and psychological symptoms are not going to have the capacity to understand, to be able to give informed consent. We need to go to a person responsible. If the patient lacks capacity but is accepting the treatment, then it can be a person responsible. So that would be, according to the hierarchy, it would be the spouse, whether that's de facto or after marriage, but the spouse. Then it would be the person who is really providing the day-to-day care in an unpaid manner, if they lack capacity. But if the patient is refusing the treatment, so a patient is spitting out the medications, clamping their mouth shut, not taking them, or if they're actively trying to leave the facility or rattling the doors, really trying to get out and escape. Patients of mine who've saved the teaspoons off their tray so they can dig out under the fence in the garden, they're actively trying to leave, and the person responsible cannot give consent in New South Wales if they're actively trying to leave. And in this case, it needs an application to the guardianship, to the New South Wales Civil and Administrative Tribunal Guardianship Division, to have a guardian appointed who has the power to authorise restrictive practices. We used to call this coercive powers, but now it is the power to authorise restrictive practices. Now, this is, I'm afraid, going to apply to a lot of the patients that I am called to see and the older person's mental health team are called to see. This is not within hospitals, it's only within aged care facilities. That I think that is an extremely subtle difference. My personal feeling is that it should be the same rules within hospitals. This came as a test case to the NCAT in the middle of the year from multiple applications to the NCAT by Concord Hospital in Sydney, with patients who had BPSD, requiring restrictive practices and actively refusing. And the NCAT carefully considered it. They delayed consideration until there were similar cases heard in South Australia, and then determined that the hospital would be treating a person with a medical or psychiatric condition. That's why the person was in the hospital in the first place, and therefore it was treatment, and that there was no need to apply to the NCAT because it was treatment rather than a restrictive practice primarily for controlling behaviour. But we still need to have consent from a person responsible. All right, that is the end of my actual scheduled talk. And now there are some times, not much time, but there's time for questions. I've put a few extra resources here. If you really want to know about the changes to the law, how it applies to you, and Capacity Australia is a wonderful resource, both for doctors, psychiatrists, geriatricians, GPs. There's also pages on Capacity Australia for families and carers, non-professionals, and some pages, some information for people with early cognitive impairment to guide them as well, or links to other places for people with early cognitive impairment. This article that was published in the British Medical Journal earlier this year is a wonderful summary with a few more details of what I have said. It's from Britain, but it's applicable to Australia. And the last web resource has got a huge number of both text and webinar resources for anybody in all areas, professional areas, caring for patients with dementia and behavioural psychological symptoms. Right, Jodie, questions?
Wow, I'm not sure about you guys, but my head's spinning with information and content. That was extremely informative and on point, Tamiko, so thank you so much for that. We actually haven't had any questions pop up. If you've got a question at the moment, please feel free to pop that in the question and answer. Or if you want to put your hand up, there's a toolbar on the bottom of your screen. You can raise your hand and I can allow you to speak. If you would like to just ask Tamiko a question directly, that's fine as well. Just having a bit of a look at the chat. Very empowering and informative presentation, Tamiko. Thank you.
Thank you. I can see that Danielle Davis from the BASIS team is online. Danielle, you've probably got some things you might want to add about practicalities from behaviour management plans or contacting BASIS.
Danielle, I've just allowed you to talk. Go ahead.
That was good timing. I just raised my hand too, Tamiko. Look, that was a great presentation. Thanks, Tamiko. And I think you've covered a lot in a short amount of time. And I think a good summary of the Royal Commission stuff for me. Some of that I didn't know about yet and haven't sort of covered it yet. I guess one of the question I had around the prescription of the antipsychotics by either the geriatrician or psychiatrist that you mentioned comes in on the 1st of November. I'm wondering how locally we're thinking that's going to look, or how.
So I think locally, I really am not going to expect a lot of changes because I don't think many people are aware of these changes, and I'm especially concerned that I don't think many GPs are aware of it. I expect that as an awareness increases, particularly amongst the aged care facilities, we're likely to have lots of referrals to geriatrics or older persons mental health team. This is a concern across the state, and there is a statewide working party from geriatrics about this, where we have approached and are approaching both New South Wales Health and federal government, asking for enhancement of funding for outreach services to be able to actually meet these requirements. But, you know, again, COVID has kind of hijacked that. So the expansion of the outreach services that we were hoping to be able to achieve here locally has been delayed, and funding is likely to be very minimal, realistically, I think. But yeah, we're expecting lots of referrals.
Yeah, I think we in our team, we've already seen an increase in referrals with the new SIRS, the incident reporting that's happening in aged care, and people sort of feeling like they need referrals as soon as an incident occurs for behaviour management planning.
Yeah.
And I guess we've been talking just within our service about how we can help with upskilling and educating aged care facilities, which will be really helpful to when that pro forma or template or whatever you called it, New South Wales Health comes through. I think that will be a useful tool for us to do that.
One of the things that I think that we can help the aged care facilities and also help prevent getting lots of referrals is important, that what we can do here in the hospital already. So I also see that there's quite a few supported transitional care staff on the line and social workers. So what I'm really hoping is that if we are sending patients back to their nursing homes or to new patients to nursing homes who are on major tranquilizers or who have BPSD, that we're actually putting that into the discharge summary, what the purpose is, and we're scheduling a review of that medication at the discharge, so that the nursing homes don't have to go, oh, well, who's done this? Why is it on it? But it's already there on the discharge summary. So I've already started doing some work here at Wyong Hospital, talking to the junior medical staff who write the discharge summaries, and we also the Department of Geriatric Medicine, who get a lot of the referrals for consultation work here in the hospital for inpatients who are then going to nursing homes. We are sort of trying to gradually case by case upskill staff and make sure that is there. And it'd be really helpful if the social workers and the discharge planners or STCT nursing staff know this, and also then you can be proactive and say, this patient is on a major tranquilizer, this person has behavioural problems and is going to a new facility. Can that be included on the discharge summary, or can you get a geriatrician to see them? Here at Wyong, we will be starting an improved outreach service with a new referral template that will make it a little bit easier for patients who are being discharged to get a geriatrician review of those things, of their behaviours or of their major tranquilizers and chemical restraint.
Thank you. Karen had a comment that those guys from the BASIS are seeming to be getting more referrals from RACFs due to needing to review antipsychotics and behavioural support plans since the changes. So that's handy. Elsie, you had a question. I'm just going to allow you to talk. If you'd like to unmute, go ahead.
Oh, thank you, Jody. Well, I had a question, but then Tomiko has just answered my question, because I had a question about those patients who are transitioning from the hospital, that sometimes if the work has started in the hospital, I think it would be really valuable for the doctors to support that medication plan and behavior plan. And so Tomiko has already explained that, which was fantastic. So thank you. And also just wanted to make a comment, Tomiko, on polypharmacy, which you touched on during your presentation. And I appreciate that from the work that I do, especially when we have 96-year-olds who are still on statins for lowering medications. They are legally blind, but they are still on Vision and all these other drugs that, you know, some of the work that I'm doing is to make recommendations if we can stop those medications when possible. So thank you.
And we can be quite supported in this, because there is funding. There's funding for patients in aged care facilities or in their own homes to have a review of their medications annually from the pharmacy. So that can help, I think, take a little bit of that load in terms of the polypharmacy.
Mm-hmm.
But I really need everybody who's listening to be advocating and asking for a review, or reminding the junior doctors to put it on the discharge summary, the purpose for the major tranquilizer and the review. Because once that's on there, then the aged care facility does not need to get another geriatrician or psychiatrist to see the patient if we've initiated it, if it's been initiated by a geriatrician or a psychiatrist. Now, I did find the other day that, although I've worked here for 22 years and I really kind of feel like part of the furniture of Wyong Hospital, somebody didn't know who I was and wanted a geriatrician to see a person because Dr. Barrett had started this drug. So I think we have to make sure we're actually writing started by Dr. Barrett, geriatrician or old age psychiatrist, just to be helpful for the aged care facilities to prevent unnecessary work or redoing it.
Thank you. Now, there was somebody else's hand up, but that's now been lowered. So I'm making the assumption that you've already answered the question during the content. But if that was a mistake, please feel free to raise your hand.
Claire has asked a question, Jody, that I'll have to answer it. Claire Sway has asked, if a GP has prescribed the antipsychotic 6 months ago, does it need to be reviewed by a geriatrician or an old age psychiatrist? The answer to that is, if it was prescribed 6 months ago, it needs a review about whether or not it should continue. That's the first thing. And if you thought if the BPSD or the symptoms that it was used for have resolved, then it could start to be titrated down. If it couldn't be titrated down, yes, it does need to have a geriatrician or a psychiatrist authorise it. So even if people have been on it for a long time, it has to actually have been approved by geriatrician or psychiatrist.
Fantastic. Thank you. We've had lots of great information. Somebody's asked in the questions if the presentation will be available. So yes, we have recorded today's session, so we can share that, and the PHN have kindly offered to post the presentation on their education page on the Primary Health Network website. So that's great. So thank you again, Tomiko, for your wealth of information and sharing your time. We know how valuable it is. You will, everybody, receive a survey at the end of the session once you've logged out. And there's also a certificate of attendance that you can use as education for CPD. So thank you again. If you need to ask any questions, please feel free to email us and get in touch. And we look forward to seeing you on the next session. Thank you, guys.
Thanks, Jodie. Bye, everyone. Have a lovely weekend.